you guys come in for an evaluation at FCI. So this Virtual Fertility 101, this is our third webinar that we're doing. Because of the pandemic, we have been seeing patients virtually, and we like to introduce to everybody sort of the timeline and also what a workup, treatment, and options would look like at FCI. I first want to start off with saying who we are as a fertility practice. Next slide. So Fertility Centers of Illinois has been open for over 30 years. Next slide. We've had many milestones in the reproductive endocrinology world, where we started in 1984. We had the first ICSI procedure done in the Midwest as well. And in 2011, we just keep progressing and getting bigger, and also getting new technology, joining the Donor Egg Bank USA, which means that we've been doing a lot of cycles, and so we're very, very good at what we do. Next slide. Not only is FCI has been around for a long time, 30 plus years, but we also have several locations in the Chicagoland area. For convenience, of course, patients can be seen in any of these clinics for testing, for monitoring, and the like. I work out of the Chicago office, and the majority of all of our doctors, we work out of 2 offices. Now, there are 2 offices that are currently closed because of the pandemic, and we're looking to open them real soon. That's in Highland Park as well as Warrenville. But given that because of the pandemic, we are doing virtual visits, all of our new patients and all of our follow-up patients are all done by Zoom. And then when patients need to do blood tests or any procedures like saline sonograms, IVF, things like that, then that's when patients come into the office in order to do those procedures. Otherwise, we do sort of this. Next slide. As I alluded to, we are a large practice of 12 different physicians, and we each go to 2 different locations. So there's definitely something for everybody. Most of our doctors, we specialize in different things. My specialty is unexplained infertility, as well as obesity and LGBTQ fertility. All of our bios are on our website. If anybody is interested in knowing a little bit more about us, you can go to fcionline.com and get to know all of the doctors a little bit more. Next slide. The first thing I want to discuss is who is coming to our offices. Why would you come to see a fertility specialist? And we see all sorts of different couples, like I said. We see heterosexual couples, same-sex couples, single parents, transgender couples. And so our clinic really is equipped to see and to be able to treat any and all patients who walk in our door. So who should be coming to see us? For any woman who is less than 35 years of age, if you've been trying for 12 years or more, or if you've been having unprotected intercourse for 12 months or more, and that's when we would recommend an evaluation for fertility. For any woman who's greater than 35, who's 35 or greater, then that's when we start to recommend to start a workup starting around after 6 months of trying. We also recommend anybody who may have any issues with fertility, such as irregular cycles, advanced maternal age, greater than 40 years of age. It is generally recommended after 3 months of trying to come see a fertility doctor for an evaluation. Next slide. So how can you make an appointment to see one of our doctors? First is by calling our new patient call center. The phone number is on the slide, 877-324-4483. This way we can establish your medical records, we can establish and verify your insurance, and make sure that you are ready to go when you start to see the doctors at FCI. This is the best way as well, that we're going to be communicating through email, sending you the links to the Zoom consultation so that the day of the consult, you have everything ready to be able to see the doctor that day. Next slide. So what is it going to look like the first day that you see one of our doctors? So first of all, we want to know more about what is going on with your menstrual cycle, how long you've been trying to get pregnant. We want to know more information about your medical history, surgical history, family history. We go through all medications that are being prescribed, as well as trying to pinpoint what could be a reason for the infertility, as well as guiding patients for an initial workup, which I will go into. This first appointment really is, at least for myself, is to really listen to the patient and see how I can help. Everybody is different. Everybody has their own journey, as well as their own medical history. And so not everybody is the same. And this is the time that I like to take to get to know the couple a little bit better, to see what has been done, what hasn't been done. Has there been a workup with your OBGYN prior to seeing us? Are you coming in as a blank state? Trying to just get all the information that we need in order to formulate a plan in order to do a full evaluation. Next slide. Now, a fertility evaluation will definitely depend on different circumstances. I'm going to go over what a basic fertility workup is going to look like, although many patients will have a lot more tests involved because not everybody is the same, and we like to tailor everybody's workup and treatment based on their own characteristics. But in general, the fertility evaluation starts off with looking at what's called the ovarian reserve testing. And the reason for this is because women are born with a set number of eggs, as we know, and then throughout the reproductive years, egg count starts to go down. And so we want to evaluate the reserve of eggs in the ovaries in order to make a sound judgment of a diagnosis and treatment plan. Next slide. So one of the parts of the ovarian reserve testing is a transvaginal ultrasound, and this is done in the beginning of the menstrual period. So the ovarian reserve testing is done on days 2, 3, or 4 of the menstrual cycle. Usually after the first appointment, patients will call in with their first day of their period and then get started with the evaluation. So this is what an ovary would look like under with an ultrasound. We're looking at these black circles. Those little black circles are follicles in the ovary, and each one of those follicles contain an egg. And so we do a follicle count. And the reason for that is because there is a correlation between the follicle count and the egg reserve. The more eggs that we see in the ovaries, the more eggs that the patient has. Next slide. Another test that we always get is called the AMH, the anti-Mullerian hormone. And the way that I explain this to my patients is basically the AMH hormone is secreted by these small and large preantral follicles, okay? And so these follicles are the pool of eggs that a woman would have. So the more eggs that a woman has, the higher their AMH level will be in their blood. And so we're looking for an AMH level for ovarian reserve. Next slide. The third and last component of an ovarian reserve testing is to look at the gonadotropins, or the hormones that control the menstrual cycle. We know that in the beginning of the menstrual period, there's going to be an opposite relationship between egg quantity and the level of FSH. Here in the diagram, you can see how FSH and LH and estrogen and progesterone changes throughout the menstrual cycle. And this is why patients will come in at the beginning of the cycle, because then we know that their FSH level should be low if you have a good and normal count. So that's what we get. Next slide. The second part of the evaluation would be in a separate appointment. So the first appointment is done between cycles day 2 through 4 for the ovarian reserve testing, and that is one appointment. Then the second appointment, we want to look really into the pelvic anatomy. We want to know if there's any anatomical problems that could be preventing someone from getting pregnant. And the way that we evaluate this is either with a saline sonohysterogram or a hysterosalpingogram. Those are just fancy words for either putting saline water inside of the uterus and doing an ultrasound to look at the inside of the cavity, making sure there aren't any polyps, fibroids, scar tissue, septums, some anomaly that can prevent pregnancy. We're also looking to make sure that the fallopian tubes are open. We put air and water down the fallopian tubes to see if they are open. And the reason for that is because if tubes are blocked, then the egg and the sperm are not able to meet each other because fertilization occurs in the fallopian tubes, and that is where the egg and the sperm meet. So we want to know if the tubes are open or not, and if there's any problems in the pelvic anatomy. Next slide. So this is a picture representation of what a saline sonogram looks like on the left and what an HSG looks like on the right. So saline on the left, HSG on the right. So here you can see that there is something inside of the cavity that looks like a fibroid, which would have a negative impact on implantation and pregnancy. And therefore, we would surgically remove this fibroid before helping a patient getting pregnant. So this is how a saline sonogram would look like. Opposite to that is a hysterosalpingogram. And with this test, we are looking at the same thing, but in a different way. We're putting contrast solution inside of the uterus and then taking an X-ray, and we can see the outline of the inside of the cavity. And in this example, it looks completely normal. There's nothing on the inside. And then you can also look and trace both of the fallopian tubes as they open inside of the abdominal cavity. And we know based on this test that the tubes and the uterus look normal. Next slide. And the third component of a basic fertility evaluation would be a semen analysis. So for men, we recommend abstaining from ejaculating for 2 to 5 days and then providing us a sample. In the lab, we're going to be looking at sperm concentration, we're looking at sperm motility, and we're looking at sperm morphology. These 3 parameters will give us an idea of the fertility potential of the men. Now, why are we looking at these parameters? We know that there has to be a certain density of sperm, a certain density of motile sperm and normal looking sperm in order for the sperm to meet the egg and therefore cause fertilization on a pregnancy, of course. And so if there's any abnormalities, then we would do a workup for male factor. Next slide. And like I said, there's going to be several other tests also in this first evaluation, and that's going to be determined based on your past medical history, menstrual history, and everything that has been discussed in the first appointment, so that when the follow-up in the next 4 to 6 weeks, the patients will do a follow-up appointment in order to go over all the results, discuss what they mean, and then really come up with a treatment plan. So that would be the next step. Next slide. And so I'm going to hand over the presentation to Betsy, our fertility nurse, who is going to discuss what these next steps are going to look like.
Thank you, Dr. Alvarez. Hi, my name is Betsy, and I am the nurse practitioner at Fertility Centers of Illinois. I've been with Fertility Centers of Illinois for the last 6 years, 4 years as a nurse and 2 years as the nurse practitioner. And the reason that I really enjoy working at Fertility Centers of Illinois is because of the relationships that I'm able to make with my patients. We're able to be there to celebrate those really high moments with our patients and help them through those really low lows, and be there to support them through everything that's in between. This creates a really special bond between the staff and the patients. At FCI, the majority of your communication will be with your nursing team. So each physician has a set of nurses that will be your main source of contact. You may have an occasional procedure that's done by a different physician or may have a conversation with a different nurse, but the majority of your care will be taken care of by your healthcare team to help increase the continuity of your care. The nursing team will also be the ones that get you in touch with the rest of the members of your team. So they are the ones that after you meet with your physician and determine the treatment plan that you decide on, they are the ones that will let the financial team know what the treatment plan will be so that they can relay that information to your insurance to get the approval. And will also be the ones that will let you know when the financial team has received that financial approval so that you are able to move forward with treatment. The nurses will also get you in contact with the other members of your team: andrology, ultrasound, phlebotomy, embryology, and our third-party team, which helps individuals working with gestational carriers, egg donors, and known sperm donors as well. The nurses will also be the ones that break down each step of the way for you. So as Dr. Alvarez said, you'll meet with your physician. Right now, obviously, it's through Zoom, and then either through the portal. We do have a patient portal that we communicate with patients with, or a phone call, or hopefully sometime soon in person. You will get in contact with your nurse afterwards to go through the breakdown and the logistics of your care. They'll be the ones that will help you order your medications through your specialty pharmacy. So each insurance does sometimes require us go through a specific pharmacy for those medications in your care. They'll also give you an estimate of the timeline, and then they'll remind you of those things in those checklists, as Dr. Alvarez talked about with you, that we need before we're able to move forward with your care. This is also a great time to ask nurses questions. We know that there's a lot of questions when you go through this process, so know that any question that you have, our nurses are able to help you out or get you in touch with the person that is able to do that. In addition, each time a patient comes in for blood work and ultrasound, it's the nurse that will relay the physician's resulting and next steps for that day. So they'll tell you what is your next step moving forward, what items we need to proceed. And then once again, they can review items or questions that you may have at this time too. So there's always going to be a nurse available to talk to throughout when you're going through treatment as well. The nursing team is also going to be your educators and their resource providers. We do have a lot of education materials on our website, support groups, information about different types of infertility, information about using third-party cases. In addition to that, we also have videos that go through medications and how to use those medications. There are certain types of treatment plans that do involve patients taking injections at home. So we do have information on how to take those, along with videos that we do send out that go through each type of treatment plan that you may experience. The nursing team also will get you in touch with those people that can help with the emotional aspects of your care. We know that this is not only a physically challenging process to go through, but also an extremely emotionally challenging process to go through at times as well. We do have an on-staff psychologist that they are meeting with patients through Zoom, and you will hear from them later, that you are able to meet with through your care. And then we also do work closely with Pulling Down the Moon, who are also able to support you through your journey as well. The nursing team also is going to be there for you in anything that you need. It's our nursing team that knows that that this is not something that you expect to go through, but is something that we can do to support you through your journey. We're able to answer any questions that you may have. We do typically get back to you within 48 hours of the question that you have. There is no such thing as a silly question. We help you go through those, relay and differentiate those facts versus the myths, and help answer any questions that you may have and support you through that journey as well. In addition to this, I just wanted to go through a couple of tips that will help you through your fertility journey. So first, this isn't a time to start new stressors. So it's not a time to start a new job or buy a new home or start a new diet, but rather it's a time to pamper and take care of yourself. The other item that I would say is that this is a time that we would say to try to limit travel as much as possible. During treatment, we do require you to come in for appointments based on how your body is responding to medications. So the nursing team and the physicians will give you an idea of your treatment plan and the timeline, but it is hard to guess. So it's important that you're available to come in as much as possible. In addition, in kind of going off of that, take things day by day. A lot of this does have a lot of twists and turns along your journey. So trying to stay present in the moment and going with the advising of your physician and your nursing team is super important as well. And finally, ask questions. We know that this can be a challenging time, and we are here for you no matter what you need. Please never hesitate to ask. If we don't know the answers, we get you in the hands of someone who does, and we are always going to be here for you. With that, I would like to pass the torch over to Brenna with our andrology team.
Hi, everybody. My name is Brenna Boyd, and I have been with FCI for about 3.5 years working in the andrology lab. Next slide. So the first thing I want to answer is, what is andrology? And so andrology is the study of the male reproductive system. So the main focus of our laboratory is to receive and process all of the semen samples, either for analysis or preparation for insemination. Right now, we have 3 of our offices open for andrology services, which are Glenview and Hinsdale Monday through Friday, and River North 7 days a week. But keep on the lookout for some exciting news and updates in the coming month. Next slide, please. So the main services that andrology offers are semen analysis, which is a standard part of your male workup. And as Dr. Alvarez alluded to earlier, we're going to analyze the semen sample for count, motility, and morphology, which we'll review more shortly. We also prepare sperm for intrauterine insemination, when we actually take the sperm and wash it and prepare it to be directly inseminated into the uterus through a small thin catheter. And we do this with partner, known donor, and anonymous donors. We also have cryopreservation or freezing capabilities at fertility centers of Illinois, where we can freeze a sample for later use with IUI or IVF and also receive anonymous frozen donor samples. Next slide. So with a semen analysis, as Dr. Alvarez says, we're going to look at count, how many are there, morphology, how do they look, and motility, how well are they moving and also moving forward. So we use a computer program for both count and motility. You can see pictured there below in order to look at the shape. And over in the box here, I'm not going to bore you with the details, but we have some of our standard parameters that we use for concentration more than 15 million, total motility over 40%, and morphology greater than or equal to 14% normal looking. Next slide. So this is a brief video that we actually took in our laboratory of a washed and prepared semen sample. So as you can see in the background of this slide, there's not a lot of debris and the sperm are moving quickly and in nice straightforward progression. So this is the type of sample we love to see for an insemination. So right now, in order to collect your samples, we recommend that you abstain for ejaculation for 2 to 5 days. Samples are produced into a sterile cup via masturbation, and collection kits containing any paperwork and instruction are available at any of our FCI locations. We ask that samples be produced no more than 2 hours before your scheduled appointment time and are kept close to body temperature during transport. Due to the pandemic, we do strongly encourage all of our patients to produce samples off-site and bring them to the clinic at their scheduled appointment time at this time. So once we have all these numbers together, we provide these numbers to your physician and they can help offer any supplements or lifestyle factors to help keep your sperm super. And with that, I'm going to pass it back to Dr. Alvarez to review some of the treatment plans. Thanks, guys.
Hello. All right. Excellent. So now that you guys have an idea of what the initial workup would look like, so our second appointment will be somewhere around 3 to 4 weeks after that initial evaluation. We have to wait for a period, do the evaluation, and then right after, then we meet to be able to go over all the test results. So ovarian reserve testing, saline sonogram, and sperm analysis. And based on these tests and various other tests, depending on the specific situation, then the physician and the patient really sit down, discuss the results, and then go over some treatment options. I'm going to go over a couple of those treatment options. And again, it will vary depending on specific situations. But overall, we tend to do several things. One would be to do an ovarian stimulation. Next slide. So in a natural cycle, women only ovulate one egg, and that's the one egg that everybody has each month to get pregnant. And so in order to increase the odds of pregnancy, we can do ovarian stimulation with either oral medication or injectable hormones. And this is going to be all dependent on the test results. So the purpose of this is to really stimulate the ovary to get 2 or 3, maybe maximum of 4 eggs, depending on on female age so that we're increasing the odds that you're getting pregnant each month, sorry. And this can be either with timed intercourse if the semen analysis looks all normal, or it can also be, and depending on the diagnosis. So that's something very important that we go over in the second appointment, is really reviewing all the test results, and then what is the diagnosis. That's very important in order to discuss treatment plans. So it could be either timed intercourse, like I said, during the time of ovulation. That could be done in many different ways, which would be discussed during that evaluation, and or to do an artificial insemination, also known as an intrauterine insemination, or IUI. Next slide. So as Brenna spoke about the IUI, we do a sperm wash. So we're really just getting rid of all the debris, all of the proteins and prostaglandins and all the dead, not moving sperm. And then we're really concentrating all those fast moving sperm into a little pellet in a small amount in order to introduce all the sperm through the cervix into the uterus. And we're putting the sperm as close to the egg as we can in order for the sperm to find the egg for fertilization. So this is what an intrauterine insemination would look like. And it can either be done with ovarian stimulation or in a natural cycle. It all depends on the diagnosis, but this is one of the treatment options. Next slide. Another treatment option would be by IVF. And so with IVF, we're really trying to stimulate the ovary again, but really trying to get as many eggs as we can from the ovary. Because fertilization happens in the body with timed intercourse or an IUI, we want to limit the number of eggs that get ovulated, because then there's a risk of twins and triplets and quadruplets. So with IVF, we can really stimulate the ovary so we can extract as many eggs as we can. So here on the left side, you can see what an ovary would look like. And just in the beginning of a cycle, all the follicles are small. As we stimulate the follicles with hormone injections during the IVF process, these follicles start to grow. And as the follicle grows, the egg gets prepared to be mature. And then with IVF, we're able to do a transvaginal egg aspiration. We go right into each follicle and we suck out the eggs. Next slide. So this is a diagram of what a transvaginal egg aspiration would look like. So with the ultrasound, we can see the follicle, and then we have a needle guide. The needle goes right through the vaginal wall, right into the ovary. And then once we're inside of the ovary, we go into each of the follicles and we take the eggs out. Once the eggs are outside of the body, then we look at the eggs in the lab and we fertilize them. Okay, next slide. Now, there are two ways of fertilizing the eggs, and this will all depend on your workup as well. And you would be counseled on the two different types. But basically, there's a conventional IVF, and then there's the ICSI, intracytoplasmic sperm injection. So with a conventional IVF, we're really putting a single egg with a bunch of 10,000 to 100,000 sperm around it in order for the sperm to fertilize that egg on its own. Or we also do the intracytoplasmic sperm injection, ICSI, where we in the lab, we pick the best sperm and then we inject it directly into the egg for fertilization. And now again, this is all dependent on diagnosis and treatment and workup. Next slide. So after fertilization, we take after we do the fertilization, the next day we look to see if the eggs are fertilized. And then after that, we start to see embryo development. So here we're looking at the progression of what a fertilized egg will go through. So it turns into a 2-cell embryo, then 4, 8 morula, then a blastocyst. So it is exponentially dividing and exponentially getting bigger as it matures. And then on the 5th day of development, which would be an expanded blastocyst, then we can actually do either an embryo transfer. We can freeze the embryos. We can genetically test the embryos and freeze them. So there's a lot of different things that can be done with the embryo. And again, that would be dependent on diagnosis and treatment plan that is discussed with the doctor. Next slide. So the way that we do the embryo transfer is very similar to an IUI, I would say, but it's a little bit more controlled. We do a ultrasound guided embryo transfer where we put a single embryo or multiple embryos, depending on the treatment plan. We put the embryo right in the catheter, and we put the catheter through the cervix into the uterus, and then we deposit the embryo right in the middle of the uterine cavity. Then about 14 days after the embryo transfer, we do a pregnancy test to see. So this is really encompassing all of the treatment options that we have. And again, like I said, it all depends on the diagnosis and also talking with your doctor. So we're going to be talking with some of our embryologists to get to know a little bit more of the details that go into in the embryology lab once those eggs are out. So here's Rebecca and Mariana.
Hi, my name is Rebecca Brohammer, and I've been with FCI for 18 years now, so since the beginning here. And this is Mariana. She is one of our supervisors too. Jurgen's our lab director, and unfortunately he couldn't be here today, but there's 10 of us total in the lab, and we're just going to talk about what goes on behind the scenes in the lab.
Next slide, please. Okay, you can do the next slide, please, Marian. All right, so this is a list of all the procedures we do in the lab. Brenna and their team in andrology prep sperm for IUIs, but we do all our own sperm preps for the IVF patients. So on any given day, one of us may be preparing sperm, another one may be doing the egg retrieval. So we're searching for the eggs under the microscope. Later in the day, we'll be doing the ICSI procedure or the conventional IVF procedure. We're checking for embryo development, transferring embryos, freezing embryos, or also biopsying embryos, where we take a little piece of the outer cells of the embryo to test them genetically, and then we freeze those embryos. So on any given day, these are all the procedures that we may be doing in the lab. Next slide, please.
Like I said, we have 10 embryologists total in the lab. So we make sure that everybody learns every skill from the previous slide. We do competency testing every year to make sure everybody's doing everything the same way. And we want to make sure everybody is proficient in every step of the way. Next slide.
Okay, and this is actually a video of the ICSI procedure. You can press play, Marin. So this is a mature egg. You can tell that the egg is mature. You'll see a little ball at the top of the egg, which is the polar body. It tells us that the egg is ready to be injected with sperm. The sperm is inside this little needle here. So in order to do ICSI, you actually have to break the membrane, get inside of the egg, and then we break what's called the cytoplasm, which is inside the egg. And then we go and deposit the sperm right in the middle of the egg. So it's a very gentle procedure, and we do this for over 90% of our patients because it does treat any male factor. It works, it's very successful. So that's that. Next slide, please.
And this video here shows a time lapse of the embryo as it goes from just fertilized, where you can see the 2 pronuclei in there. And then here it's about day 3. And then these cells will start to compact and form in a morula. And then here you can see the cells are starting to differentiate. And that is a really nice blastocyst. And that's what we like to see. At that stage is the stage when we would either do a transfer, freeze it, or we could do the genetic testing.
It's also important to note that all eggs don't fertilize normally, and all eggs that do fertilize don't make blastocysts. So on average, about 70 to 80% of eggs fertilize normally. And from the eggs that fertilize normally, around 40% typically make a blastocyst. The remaining embryos, they may stop developing or arrest around day 3 or day 4 and not make a full blastocyst. So I think it's important for patients to know that not all eggs that are retrieved necessarily make a blastocyst. It certainly throughout the 5 to 6 days of development, the embryos may not develop. Next slide, please. So cryopreservation or freezing is another big aspect that we do in the lab. FCI was one of the first labs to adopt vitrification, which is a new type of freezing, and it's safer for eggs and embryos. So we're highly skilled in it, and this is something we do every day. So this is when we would freeze an embryo, and then if a patient wants to come back a month later or 10 years later, it stays in the exact same place that it was when it was frozen. Next slide, please.
And we like to have our goal here at FCI is to have a single healthy baby. So we do try to do single embryo transfers, especially if it's your first cycle and you're young. The blastocyst is, from what you saw in a couple slides ago, we do really well. Our pregnancy rate is really good, transferring one embryo.
Next slide, please. All right, so this is our lab team. Again, there's 11 of us, including our lab clerk, and we all love what we do. We wouldn't be here if we didn't, and we thank you all for, showing some interest in the lab. Next slide, please. Okay. And I believe next, Maren, who is our...
All right, so now that I don't know how to get my screen back up. Oh, here we go. Okay, so now that we've all heard what goes on in the lab, in the clinic, we really also have other great different, what am I trying to say? We have great support systems that we offer here at FCI, which we're going to be talking about. The first one is going to be Dr. Tiffany Edwards. She is part of our behavioral health specialist.
Hey everyone, it's a pleasure to be part of the panel. Like Dr. Alvarez said, my name is Tiffany Edwards and I'm the clinical psychologist with FCI. I am part of the behavioral health team. Next slide, Maren. We really appreciate that treatment can be both an exciting time, but it can also be very stressful. You know, there's a certain level of uncertainty that I think is built into treatment. So we are really here as a service to help to best and support patients kind of as they go through this journey. We are a team that is available at multiple FCI clinic locations, and we're typically available Monday through Saturday for all patients. Patients at any point kind of in their journey through treatment can meet with us, and the first session is absolutely complimentary, and you can meet with us at any stage in your treatment journey. There are patients that meet with us at the very beginning because they really want to talk through what this is going to entail. They'll oftentimes want to maybe strategize and to learn coping strategies, so as they go through treatment, they're prepped to deal with any uncertainty, deal with the emotional ups and downs, deal with if they have any medication and reactions. There are patients too that may not start with us in the beginning, but kind of as they've gone through treatment, and if they feel very overwhelmed or it's more involved and more invasive than what they imagined, then they might meet with us kind of at the middle of their treatment. Maybe they've experienced a loss or had a plan in their treatment that didn't go as to what they thought that it would. So they'll oftentimes meet with us kind of in the middle of their treatment just to get some additional coping strategies and additional support. And then there are some patients that meet with us towards the end of their treatment journey. Maybe they've experienced loss, or maybe they're kind of at the point into where they're ready to explore maybe some different options in terms of family planning. So we'll let times talk with patients maybe about looking at donor or looking at maybe adoption options, or just coming to terms maybe with changing their plans for family and sort of what that means. So we're available to talk with any FCI patient at any point in your journey, whether you're just at the beginning or whether you're at the end. We are available to talk with patients. We're available to talk with your spouse, with your partner, with family members also. In addition to the supportive consultations that we offer for any FCI patient, we also do consultations with all intended parents that are using third-party services. So when I say third-party services, that includes using donor, whether it's an anonymous donor through FCI's donor program, or it's a known donor, a known sperm donor, or a known egg donor, or a gestational surrogate. And this is one of our mandated consults that we do with all intended parents that are exploring third-party services. Typically in that consultation, what I'll do is start off by just kind of assessing where the patient is at the emotional level, what the need to explore donor, just to get a sense if this is something that they're comfortable with, that they're ready and assured that this is the right option for them. If they are, then we'll oftentimes talk through the process of what it is like to choose your donor, what might they be looking for, what are they basing that choice on. We'll also talk about those issues like if they're planning to disclose to their child, if they're planning to tell this child that they used donor, that they were donor conceived. We'll also talk through if they're planning to tell others that they used a donor or a surrogate, if you will, and sort of when they're timing both of those disclosure plans. Next slide. In addition to the opportunity and to work with us kind of one-on-one, whether it's through a third-party consultation or as a supportive consultation, we also offer group options through FCI. And these are not only open to FCI patients, but these are open to non-FCI patients also. So even if you're not a patient through FCI, you can still attend these groups. And we typically just ask that people go through FCI's website to register, but you don't need to be an actual patient to attend any of our groups. The first group is No Partner Needed. It is a group that's typically for women that are single and doing this on their own. It's a very popular group. The group is very fun and lively, and it's relatively large also. It typically meets on Monday evenings at the River North Clinic location, but all groups there with Zoom currently because of the current kind of conditions with the COVID-19 pandemic. We also offer infertility support group in general. This is for any patient doing any type of treatment at FCI, or if you're thinking about treatment, it's just really a group that's kind of open to anyone that's exploring infertility options. And then we have a third group. It's a group specific for those patients or those individuals that have experienced pregnancy loss at any stage in their treatment or just at any stage in general. And that is a quarterly group that typically meets on Saturday mornings. So those are our services, but I think that I just want you to know that at any point, if you ever want to reach out to us with questions or need additional support, that we're here to really best and support our patients. And with that being said, I will now pass the torch on to Rose Gallucci that will talk more about your insurance options.
Thank you, Tiffany. Not sure why you can't. Can anyone see me? Everyone see me on the screen? No, huh?
No.
Okay, I'm not sure why. Here we go. Okay, here we go. All right. Hello, everyone. My name is Rose Gallucci. I am the Revenue Cycle Senior Manager of the business office. I have been here with FCI for 2 years at the end of this month. And I oversee the financial and accounts receivable for the physicians group here. So during your treatment journey here at FCI, a financial coordinator will be assigned to you, and the financial coordinator will provide you with your insurance coverage information, any specific plan coverage, and inform you of your out-of-pocket amount that you will be responsible for. If you do not have insurance coverage, the financial coordinator will also provide you with different options, self-pay payment options, including also we do have loan vendors for credit options. Once we verify your insurance, you will receive a welcome letter providing your insurance coverage, and that will give you a breakdown and a better sense of what you may possibly owe out of pocket. Illinois is also a state mandated. It is a law to state, the state mandates that we provide fertility coverage. What exactly does that mean? The law requires that insurance companies provide coverage for infertility to employee groups of more than 25. The law does not apply to individual policies or smaller groups policies where the employees have 25 or fewer employees, or if the policy is written outside of Illinois. So you may reside in Illinois, but if you work for a company that is outside of Illinois, it may most likely not be fertility coverage. So it also depends on where the plan is actually written. Infertility coverage may include different types of treatment plans, and it all depends on the type of plan that you have. So for example, part of your coverage could be diagnostic testing only. It may include diagnostic testing and treatment. There are also plans that have a dollar limit per calendar year, but there's also plans that have a lifetime max. And then there's plans that have a lifetime max with also a different lifetime max that is relevant to the pharmacy items that's needed for fertility. So the plans that, and then there's also plans that cover all treatment options that we provide. The other terms that you will hear from your financial coordinator is your copay, coinsurance, and deductible. Your copay is the amount that a patient owes at the time of service. Typically, this is also stated on your insurance card. You will see an amount of your, what they call a PCP, your primary care physician, or your specialists. And this is based on the agreement with the insurance provider. And that typically ranges from $25 to $50 or $60 could be the highest of your copay. Then there's also the coinsurance. This is the amount due from the patient after insurance has paid its portion. For example, an insurance receives a claim from our office charge, and your insurance portion may cover 80%, and then you are due, the patient owes 20%. And that is considered what we consider co-insurance. There's also your deductible. This is your annual amount that a patient owes before the insurance pays for any of the covered services. We also have specific insurance plans that require prior authorization before any services are covered, and actually we do receive an authorization number from the insurance payer. Without that pre-authorization, we will not get paid, and it is not then considered a covered service. And this typically takes about 15 business days with most of our payers. Your treatment options is also discussed, and they're decided with your physician and your nurse. So once your treatment plan has been decided, then what happens is the nurse enters the treatment plan. We then receive that in the central business office, and it's usually 24 hours later, it will appear in our system. And then the insurance authorization team will review that and submit it to your insurance within the 3 business days. And then once it is approved, it's what we call green lighted with your financial coordinator. And then you are ready for your services to begin. And next, I would like to introduce Tammy Quinn, our holistic medicine specialist.
Thank you, Rose. And I am Tammy Quinn. I'm the co-founder of Pulling Down the Moon, which is a center that specializes in holistic fertility. And we'll get into that in a little bit. Maren, if you can skip to the next slide. So one of the things that we know, I'm a former fertility patient, and my business partner, Beth Heller, she is also took her, I think something like 5 years to have 2 children and multiple miscarriages and a stillbirth. And it was a very long journey, as it is for many of you. And one thing we've learned as fertility patients is that it can affect all aspects of your life. It can affect you physically, it can affect you emotionally, mentally, financially, your relationships, and how you are in relationship with other people, including your spouse or your partner, your friends. It can affect you spiritually. We also know that sometimes you're in great hands with your doctor, with Fertility Centers of Illinois, and sometimes the science doesn't always coordinate with what your results are. And so that can feel frustrating. And so we like to think of holistic medicine as an added support system. We learned a little bit today about behavioral health, and we are going to talk to you today about how to look at a holistic approach to fertility that can include lifestyle choices and whole health, things like how you eat, how you sleep, how you're in relationship with people, what kind of stress reducing tactics or tools you have in your tool belt. And also, very importantly, how are you in community with other people to help you during this time that can be very difficult? So we know from our own experiences that having a community of like-minded people who understand what you're going through can be extremely important. And so nowadays, it's very easy to go online and to start researching and Googling and being on Facebook and Instagram and understanding from that perspective what another person's experience has been. But that isn't always the best option, because online resources can be filled with inaccurate information, mixed messaging, can make you feel very fearful, and there can also be an awful lot of opportunism. And that's why at Pulling Down the Moon, we feel it's very important to find people that you can trust, that are able to provide services based in science, based in evidence, based in traditional medicine, that can be low cost, trusted, or even free in many cases. And there are plenty of those options at Fertility Centers of Illinois and Pulling Down the Moon. Next slide, please. So what exactly is Pulling Down the Moon? I mentioned that it was founded by folks who have been through fertility themselves, who understand the process. Many of our practitioners, our acupuncturists, our massage therapists, our yoga teachers have been through fertility themselves or are specialists in women's health and hormonal issues. We are a physical center that is located in both River North, about a mile down the road from FCI, and we also have a location in Highland Park, which is close to the lab. We are a holistic center that is specific for women going through fertility, pregnancy, and postpartum. And in fact, that's probably about 99% of all the patients that we see are going through infertility or the parenting process. So it's really important, if you are going to try holistic medicine, that you find folks that work with your medical doctor, that understand the terms, the technology, the medicines, the effects of those medicines that they may have on your body, and are able to support you in conjunction in an integrated way with your doctor. We are available online. We have Zoom classes for yoga for fertility. We have telehealth options for nutrition that you might be interested in. And we're really proud of the fact that we were the first holistic fertility center in the United States, going back almost 2 decades. Next slide, please. I mentioned the importance of finding holistic medicine that is based in science, but also rooted in ancient tradition. There are 4 core competencies or services that we really focus on at Pulling Down the Moon that have evidence-based or research behind them. The first one is acupuncture, and we know that traditional Chinese medicine can be great not only for women, but for men too. And women who do acupuncture for fertility often use it to treat things like bloating, migraines, discomfort that they may be feeling, low back pain. Men find that it can be very relieving too. It's a great option for reducing stress, for helping those with insomnia, for helping with digestive issues. And we also have some research showing that acupuncture done both before and after embryo transfer during an IVF cycle can potentially enhance conception rates, which is really exciting as well. Our Yoga for Fertility program also has research behind it. We worked with FCI in really studying the women who were coming to both our online classes and our in-person classes. And we presented our findings at the American Society for Reproductive Medicine, which showed that women who take our classes actually have a 20% reduction in anxiety rates. And that's really important for those of you that are already going through this and maybe feeling a little bit stressed or anxious. We have a very specific and unique massage protocol. It's different than what you might find at your mom and pop massage or a Massage Envy. It's called Fertility Enhancing Massage. And it is a 5-part protocol that really is meant to mirror those particular points in your fertility journey, from the time that you might be stimming with your medicines to the point where you might be going through a retrieval or a transfer, or when you might be in your 2-week wait period. So the massage does things like increase blood flow. It can help decrease inflammation, help drain the lymph system. So it's really used in a very therapeutic way. And of course, it feels great to boot, which everyone can often enjoy, especially during these times. Nutrition's a big one. And I think that most doctors would agree that even a 5 or 10% increase in weight or decrease in weight can have a big impact on how your hormones work in your body. So we really like to look and see, most of you probably think you're eating a very healthy diet, and that may be the case, but we like to say or ask, are you really consuming a fertility friendly diet? And by that, we mean, are you consuming those items that are nourishing your body? We like to nourish up and make sure that you're getting nutrients that are not only good for you during the conception period, but also become good lifestyle habits while you're pregnant and then into the future when you become the caretaker for your child. There's a big question that comes up all the time about nutritional supplements, and we encourage you to discuss that with your physician. And if you have questions that you would like for us to answer, we do have nutritionists that are on board with us that can answer questions like, what is the egg quality protocol and is it right for you? What are some supplements that we can use to help sperm parameters, as we learned from andrology today, that is a measure that you may be looking at in your own fertility. Other things like, what is there anything to do for recurrent miscarriages? And while the research is still emerging on the efficacy of supplements, there are some exciting things happening in the field and some research that has come out that may be worth trying if you are someone that is experiencing any of these issues. Polycystic ovarian syndrome is another potential condition that may benefit from diet, exercise, and nutritional supplementation. So we really try to focus on providing services that have evidence-based and have been proven to make a difference, not only from scientific research, but just empirically from cases that we have seen throughout our 20 years as holistic medicine experts. Next slide, please. I will turn it over now back to Dr. Alvarez to answer your questions. Thank you.
All right. I have been going through the chat and answering some of these questions. But Marin, if anybody has any pressing questions, I can answer them. Or any of our team members can answer as well. Anything that I haven't answered so far.
Okay, so you're doing a great job.
I've been going through them. But in the meantime, if anybody also wants to follow me on Instagram, I also post a lot of educational fertility related things at Dr. Juan Pablo Alvarez. Also follow us at Fertility Centers of Illinois. We usually post any upcoming events, webinars, things like this. And then also Pulling Down the Moon at Pulling Down the Moon to get also great information, lots of facts and information of alternative medicine that can help also in the journey.
Okay, we have one that says, are patients sedated for egg retrieval and embryo transfer?
Okay, so for egg retrievals, yes, there is moderate sedation. So we have an anesthesiologist in the operating room so that you can be completely asleep and comfortable, because it is a procedure. Now for the embryo transfer, there is no sedation because it's just like the IUI. We're just putting a little catheter into the uterus and depositing the sperm, depositing the embryo, I'm sorry. For my patients, if they are anxious, I do prescribe moderate sedation like Valium or Xanax prior to the embryo transfer. So that's something that is given.
How can you avoid OHHS syndrome? So ovarian hyperstimulation.
So ovarian hyperstimulation syndrome. That's a great question. And that will be, so how to avoid it? Your doctor will try to avoid it. It just all depends on how well your ovarian reserve is, the dose of medication, how your estrogen gets. So it all really is dependent on the patient. And we always try for every single patient to try to reduce the risk of ovarian hyperstimulation. We know that in our lab, less than 2% of all IVF cycles, probably like less than 1% of IVF cycles have moderate to severe ovarian hyperstimulation. So it's very rare.
What is the chance of having a healthy baby for a 43-year-old woman with IVF?
Well, that's also dependent on ovarian reserve testing, if you've done genetic testing on your embryos. So in a 43-year-old, we know that about 80% of the embryos that are created are going to be genetically abnormal. And so if you do IVF and you do pre-implantation genetic testing, really you're taking away the age factor out of the equation. Because once we have a genetically normal embryo, we know that everybody does about the same, either a 20-year-old or a 40-year-old. The thing is that as we get older, eggs start to lose their quality, and reduce in egg quality leads to genetically abnormal embryos.
I am muted. If all results come back normal, can patients still move forward with IVF?
Yes, so that's one of the diagnoses that we do have. About 30% of all couples have the diagnosis of unexplained infertility, meaning that we have not found any specific cause or etiology for the infertility. And then for that type of diagnosis, any and all treatment options are available.
Why do you recommend transferring only one embryo at a time when you're doing IVF?
Well, that is also dependent on female age, number of embryos, quality of embryos, day of the embryo, day 3 versus day 5. But in general, yes, we only recommend to transfer one embryo, because we know that transferring 2 embryos does not significantly increase the odds of getting pregnant. It only increases the chance of having twins.
A vaccine question. Do you recommend getting the vaccine if I'm in the process of starting a fertility plan?
Yes, so the American Society of Reproductive Medicine has recently come out with a new statement as well, that any woman trying to conceive, having conceived, or is in the process of conceiving should definitely get their vaccine as soon as they can.
Do you have any info on POF or POI?
That would have to be more specific. I mean, premature ovarian failure, that's a condition when all the eggs, or the majority of the eggs, are depleted before age 40. There isn't any way for us to know who has a risk factor for POF. If you have irregular cycles early on, you may have some problems with eggs, but there really isn't any way to know if someone has POF unless we did testing.
Does IVF harm ovarian cysts?
I'm assuming that the question is, does it hurt ovarian reserve? Because those black circles, everybody calls them cysts, but they're follicles. So each one contains an egg. And no, so doing IVF does not deplete a woman's ovarian reserve. And the reason for that is because we're only stimulating the available eggs that were there for that month. So every month a woman has a cohort of eggs that only one will ovulate and the rest of them essentially go through cellular death. And so through the process of IVF, we're rescuing those eggs that would have died anyway. So we're not depleting at all the ovarian reserve by doing IVF.
Since we have a limited number of eggs, does IVF lower your egg count for the future?
No. Like I said, like I explained, it does not.
Okay. Why is there a possible correlation in taking hormone treatments and cancer?
Well, these are all based on old studies that had shown that maybe treatment with either Clomid or gonadotropins may increase the risk of cancer, especially breast cancer. But we also know that women who haven't had children, that is already a risk factor on its own. And we know that infertility by itself has an increased risk of cancer. And so multiple studies, recent studies have shown that there really is no correlation between hormone-related cancers and IVF treatment, or any fertility treatment for that matter.
Do you have patients over 40 that you've helped have a healthy baby in the past?
Yes, many.
How often do you recommend doing genetic testing?
So doing genetic testing on embryos is an option for everyone who's doing IVF. So I always talk about it for anybody who's doing IVF. Now, if we look at the literature, who would really benefit from doing genetic testing, and we really start to see the benefit of doing genetic testing around age 38 for females. Before that, there really is no significant difference in pregnancy rates in younger women with or without doing genetic testing.
Is there evidence of IVF having negative impacts on babies?
So that's a question with a lot of answers. So the studies that we're looking at, like chromosome abnormalities, genetic abnormalities through the ICSI procedure. So ICSI was invented because of male factor infertility. And so we know that if you compare the population of infertile population that get pregnant on their own, the general population that gets pregnant on their own, and then the fertility population doing IVF treatments, there really is no difference between genetic abnormalities between the infertile population that gets pregnant on their own and then the infertile population that gets pregnant through fertility services. And we think it's because there's probably an innate problem that we're trying to bypass and overcome by doing fertility treatments that may cause some problems in like genetic abnormalities in pregnancies. Now that I would counsel my patients, obviously, that really is seen in severe male factor infertility when we're using the ICSI procedure.
Okay. Do we have any more questions coming through?
I see here, are there any treatment plans for someone who has been diagnosed with POF age under 40? I would recommend to, if you're not trying to get pregnant right away, to freeze your eggs right away. All right, I'll answer this last question. Would polyps have an effect on pregnancy? Yes. So polyps, inside of the uterine cavity, so endometrial polyps, we know that they cause two problems. One, they take up space. So it's a space occupying lesion. So there's less surface area for an embryo to implant. And two, they can also secrete substances that make the lining less receptive. So if you compare women who have a polyp in situ, or if you remove them, by keeping the polyp in place, you reduce the pregnancy rates by 50%. So it does have an impact on fertility. All right, well, thank you everybody for joining us. If we have more questions, we'll make sure to answer them.
Thanks, everyone.